So I'll hand over to Kieran, Director of Health and Care Research Wales. Thank you.
Many thanks, Nikki. And I think I'll just echo everything Nikki has said about our thanks for the efforts that people have made right across the health and care system, but also in universities and in other parts of the system to make research happen over the last 12 months. So thank you. I was thinking that there's some kind of a sort of adjective shortage, I think, here. I was trying to count the adjectives that Nikki used, you know, extraordinary, unprecedented, unparalleled, unrivaled, unequaled, exceptional, to describe this last year. It's certainly, for me, I think it's been one of the most interesting years in my professional life. And what I want to do in my presentation is just try and bring some ideas together about what we might learn from the last 12 months and what's happened, and to look forwards, and it leads, I think, into very much into what Caris is going to cover, to look forwards in thinking about how we might do things differently. And I've got about 6 or 7 slides, I think, which I'll use for that, and I'm really interested in people's views about the points I'm going to make. Right from the outset, you know, last March, 13 months ago, there has been an extraordinary international effort to bring research to bear on essentially, particularly on managing the pandemic, treating COVID, preventing transmission, and developing vaccines. And it's an area where I think the UK can actually be incredibly proud of its contribution. The effort here in the UK has been very much led by UKRI, by NIHR in England, with partners in Wales, Scotland and Northern Ireland. And we can look back over the last 12 or 13 months and think it is remarkable how quickly the research effort was put in train back last March, how rapidly it delivered research on the ground, and how fast that research delivered results that made a difference to the treatment of patients with COVID. It's an area where it's really interesting to see that England has, or the UK has outperformed other countries in Europe, and particularly the USA, where there's a huge amount of resource behind health and care research. But, you know, the UK has been able to deliver things like the recovery trial, you know, a platform trial with a massive recruitment footprint, recruiting at huge pace and able to deliver results far faster than the equivalent trials architecture in the US or in other countries. And so there's a great deal to be proud of in that. You know, that terrible phrase world leading got bandied around to some cost at various stages in the pandemic, but you can genuinely say that in the therapeutics work, in variant genomics, in vaccine development and research and manufacture, the UK has actually been world leading. And it's not just about the kind of clinical research environment. You've seen a huge portfolio of research commissioned by UKRI. It's something like over 500 projects now. They've committed over £200 million in the last 12 months to that portfolio. It's all on UKRI's website if you want to go take a look. Researching a whole range of issues to do with schools, to do with mental health, to do with the cultural economy, to do with the business response, to do with transmission in a whole range of different environments, to do with the zoonotic infection area and the future for future potential infections that transfer from animals, all sorts of stuff. And it's been remarkable to see that effort put together. It's much more than just the bit that we tend to see ourselves that's focused on clinical research and clinical research delivery. There's also been a big response from Patrick Valance's part of government in Whitehall, the Government Office of Science, which has led the establishment of really big core studies in a number of areas. So things like the ONS community infection study and the school infection study have been led from Go Science, and they've invested hundreds of millions of pounds in that and other research endeavours. Equally, the work that's gone on to bring data together with the really led from HDR UK, and to completely push the boundary in how well routine data gets used to understand really important research questions to do with the pandemic, and that work's been at the foundation of the modelling effort as well. In Welsh Government, I mean, our job has been to, I think, both be UK facing in keeping a Welsh voice in all those dialogues about research and investment, and to be Wales facing in making sure the Welsh research community, the NHS in Wales, and our colleagues right across Welsh Government, where COVID has been the predominant concern for the last 13 months, are all engaged. And I think we've done that reasonably well. Just move to the next slide. It is worth reflecting on the COVID research programme in Wales and how it's worked. We've seen some really great UK leading involvement in some areas, and I think for me a standout example would be the Sale Data Bank and the work they've done on data analytics and their coronavirus cohort work. They've been able to do data linkage stuff that the rest of the UK wasn't able to do, although they are catching up. I point also to the variant genomics work, where Wales, Tom Connor and colleagues in Cardiff and others have played a really leading role in the COG UK consortium, and in the last few months with the development of variants, that work has absolutely come into its own and has been incredibly important and very visibly useful. Has sometimes been a bit of a challenge to get the Welsh voice heard at a UK level. So I mentioned the ONS community infection study. When that was initially launched, it was being launched in England, and we had to do a little bit of pushing and shoving to make sure that it was run in Wales as well, and that the sample sizes provided data that was adequate to inform Welsh policy making. But my observation, I'm sure Nikki and Caris would share this, is that in the pandemic, the collaboration across the bits of government that deal with health and care research, so ourselves in Wales, NIHR in England, the Chief Scientist's Office in Scotland, and the Research and Development Division of the Public Health Agency in Northern Ireland, I think we've seen better co-working than we've ever seen before. It's one of the things we're keen to hold on to. I think we've had really good involvement in Wales in research management and delivery, and we've played an important role in things like the Urgent Public Health Group that has prioritised COVID studies to identify those that are most urgent and need support from the NHS. And I think great involvement across the trials, but also the vaccines task force and the vaccine trials and others. Records much more mixed, I think, on the involvement of the Welsh research community in leading research studies in that UKRI portfolio. And one of the things we need to do is reflect on the reasons for this. So that portfolio that I mentioned contains, let me quote the numbers I think accurately, something like 400 studies that are led in England, 50 studies led in Scotland, and 15 studies led in Wales. Now there's a good Welsh footprint as co-ops in quite a lot of that research, but even so, I think we need to reflect as a research community on why we haven't led more of the UKRI COVID-19 portfolio. Finally, research has never been more visible in government, and you've seen that in Welsh Government in the role of the technical advisory group that has coordinated scientific advice to Welsh Government, and in the way in which this is figured in the agenda for boards and for all sorts of other agencies. What have we learned? I've got 5 key points which I think are slam dunk obvious, but worth repeating. I've just made that point that research has mattered like never before. It's never been more central to policy and practice. At the beginning of this exercise, in many areas, face masks is a great example, we were scraping around for evidence. The challenge now, I think, for policymakers and for researchers is staying abreast with an exponentially expanding field and a huge research effort. So we kind of gone from no evidence, too much evidence. I'll come back to that point in a moment. We've learned that research has got to move at the pace of the pandemic to be useful. And so the way we commissioned research has had to change. As Nikki said, the way we've set up research and delivered it has had to change. And the publication models have changed completely. And yeah, we've discovered that we can do things that used to take months and years in the space of days and weeks at some cost to the rest of the research endeavour. we'll come back perhaps to thinking about what we take forward from that in the future. There has been an increasing need for rapid evidence synthesis and knowledge mobilisation, and a real need to take the evidence that's often produced elsewhere across the UK or internationally and think about what it means for communities and for the health and care system in Wales. One of the investments we've made, which started in March, but we started working on back last summer, is an investment in an evidence centre to provide knowledge mobilisation and research synthesis. So Adrian Edwards from Cardiff University, Professor of General Practice, and a team with collaborators across Bangor and Swansea and Cardiff and Health Technology Wales, and I've probably missed, and Public Health Wales, and possibly one or two others, has been put together essentially to provide a capacity for rapid, flexible evidence synthesis and knowledge mobilisation work, and they're already getting to work on their work programme and will be available to support Welsh Government and the NHS over the next 2 years. My final slide, this is, I think, and I'm going to come to some thoughts about the legacy from the pandemic and what we might try and take out of it and hold on to. The first point is, yeah, research has been front and centre in policymakers' minds, and that is great in many ways. But we need to think about how we continue to be in that position, how we continue to make sure that health and care research is seen as being really useful, really important, and really central to decision making on health and care. I always thought it should be, and I always thought it was. But I have to say, sometimes in discussions with senior leaders in the health and care system, it seemed like research is a kind of nice to have, because there are always more urgent and more pressing priorities around delivery that they have to focus on. And I kind of understand that and sympathise. Well, in this pandemic, the only way out of the pandemic has been through research, and the results that research will provide about, you know, therapeutics, vaccines, and the management of infection. So how do we continue to keep health and care research high on the agenda for senior leaders, policymakers, for health boards, and for others? Second point is, and I think it's very much connected to the first, is how do we get a better alignment of the research agenda with the real needs of the NHS and the care system? Ever since the birth of NIHR, and I was around back in 2006, 2006 when it was set up, that the rhetoric has been that we should have a knowledge-based, needs-led, science-added research system. In other words, something which works from the needs of the NHS. And I think our progress on that has been rather mixed, to be honest. That we've not been great sometimes at delivering the research that the NHS has needed. That, you know, the research agenda has often been set by the research community itself, and sometimes that means researchers choose to research things that they think are interesting and novel, but not necessarily the things that the NHS might need. I think coming out of this pandemic, one lesson is that we need to get really good alignment so that the NHS, which the funding for Health and Care Research Wales, the funding for NIHR comes out of the NHS budget, comes out of the NHS vote, so that policymakers and leaders see that funding as a worthwhile investment because they see the results it delivers to improve care, to reduce costs, to make the NHS more productive, or whatever. And I think that might require a bit of a rethinking of the research agenda and of what matters, and perhaps, and this links to my third point, an approach to setting the research agenda that is rather more managed. So this is my third point. As Nikki said, you know, in this exercise in Wales, we've seen, you know, the once for Wales approach in a way rolled out in an emergency to make sure that we could deliver engagement in research, recruitment, setup, and all those other things, and the research workforce that was needed to support research delivery at pace and scale. We've also seen decisions being taken at a central level about what the research priorities are, which have been, I think, at times quite uncomfortable and difficult. So I mentioned the Urgent Public Health Group, which Nikki has sat on. That group sat there and looked at proposals that came in for COVID-19 research, and it said no to some of them because it said there is a limited capacity to deliver research in the NHS, and these projects are not sufficiently urgent to merit inclusion, to get the UPH badging. Now, we'd never really done that before. The threshold for going onto the portfolio has been much lower than that, has been much more a question of if a research project has funding and has been through peer review, it gets onto the portfolio. And I think there's an interesting question there about how much more managed we want that process to be in the future, how we balance investigator autonomy, diverse funder priorities, and the delivery capacity of the NHS, and how in all of that we prioritise need. And I'm not sure there's a straightforward set of answers to that. I think it was easier to think that through in relation to one disease, COVID, than it is to think it through across the whole portfolio. But we have certainly learnt that, you know, there are some advantages to being more managed. My fourth point, and again, I think it was something Nikki briefly alluded to, was we've seen all kinds of new models and new methods for research in this last 12 or 13 months. Most obviously, you know, the development of platform trials, the bringing together of the phase 2 platform trials to make collaboration across sometimes different research teams with different priorities, forcing that collaboration rather more than we would ever have done in the past. But we've also seen innovations in the use of digital and the use of routine data. Indeed, routine data and information governance, which I come to in my final point, have been transformed in the last 12 months, particularly in England, where projects like the Open Safely project led by Ben Goldacre have done things using the COVIO regulation freedoms that no one thought could be done before. We've seen ONS, for example, using, and others in government, using data to support pandemic modelling that was never used before. Data from Google on people's journeys, and using that to understand whether or not people were staying local or moving around. Data from the financial systems on transactions, so that they're able to see whether indeed people are shopping more or shopping less, or going to pubs and restaurants more or less, how people respond, in other words, to some of the requirements of lockdown. And we'd never really used any of those data sources before. I think that's opened up a set of questions on my final point, which we need to answer. I think in the past, our approach to research ethics and research governance has tended to prioritise the individual's consent, individual privacy, and any risk, however small, to the subject of research above everything else. In the COVID era, there's been a bit of a rebalancing of that and a rethinking about the ethics and research governance questions and the balance of risks and benefits. And we have, for example, used people's data in a way that I think would probably have been very difficult for CAG and other groups to sign up to in the past. So a question going forward is how much we want to retain the ability to do research using data sources, which in the past we might have found very difficult to do because of the requirements of the governance systems we put in place. So I actually think it's really exciting to be involved in health and care research now. I think there are loads of opportunities because of what we've achieved in the pandemic, amongst other things. And I think the agenda that Caris is going to set out in her presentation plays to some of those opportunities. Nikki, I'll stop there, and I'm really happy to hear questions. I haven't been able to watch the chat while I've been talking, but I think you have been watching it.
Yeah, lovely. Thank you very much, Kieran. I think an excellent overview of what we've been experiencing in the wider context as well during the year. So I've got a question to you, but first of all, I'm going to ask one that Barbara Moore has posted, which is about the increasing Welsh-led research. How do we, and how does at a local level and others on the session today, how can we all influence that to be increased?
Well, I think the answer is that there's a long history to this. That if you look at the numbers, and if you look at the numbers not just this year or last year, but going back 10 or 15 years, Wales has tended not to secure its kind of proportionate share of resources allocated at a UK level. So an example would be if you looked at, for example, the UKRI, Medical Research Council, and the ESRC, Wales has not tended to earn its proportionate share. Interestingly, Scotland on the whole has, and there are some, quite tough lessons out of that for us. Some of them for the research community, basically about it being outward looking, about it recognising that research, the footprint of research, should probably often not just be restricted to Wales, but they should be looking for partnerships and research projects that run across the UK footprint. But also some uncomfortable lessons for government, because on the whole in Wales, government has spent less, both through the Health and Social Services Group and also through HEFQ, which provides funding to universities, has spent less than government has done in England particularly. So when you sort of look at the money side of this, what you see is that actually, nearly half of all R&D in health and care research, in health and care in the UK, is industry funded. The rest is funded by public money and charity money, and some of that comes at a UK level, and some of that comes from the governments of the four nations, so Welsh Government, Scotland, Northern Ireland and England. And they're kind of really deeply interconnected and highly codependent. So there's an opportunity there, I think, for Welsh Government to invest more and to see that catalyse better performance from our universities and better, therefore, research income to Wales from UK funding sources and from industry. It's a complicated picture, and it's not just about money. I think it's partly about money. It's partly about strategy in relation to those UK funding sources, positioning ourselves to be effective. And it's partly about holding our own research organisations in Wales to account and expecting them to be ambitious and high performing and really focused. But it's not something that will be sorted out really quickly.
No, indeed, and something we can all do to encourage that, the ideas that are generated and how we then link partnerships across the UK, as you say, and wider internationally, obviously, as well, to increase that, and the support that you can provide at the policy level to leverage additional funding that pays for those grants as well. Just a final question from me then, Kieran. You talked a bit about the use of evidence in COVID, and we've had the privilege of seeing how at a government level that evidence is being used to inform the restrictions and easing of restrictions, obviously, that we've seen. And you talked about also how it's important to see that in other service developments and treatments and care pathways. So what do you think is needed to be put in place in the future to ensure that the agility that we've had during COVID doesn't get lost in normal service improvement plans for the future?
Yeah, so in COVID, I sort of skimmed over this a bit, but in COVID, I think the performance around therapeutics in traditional biomedical research, those performance around therapeutics, vaccines, genomics and so on, it's been extraordinary. We've been really much less good in some other really important areas of science. So if you take sort of the aerosol engineering area, how is it we didn't know going into this pandemic as much as we needed to know about the aerosol behaviour of coronaviruses to inform decisions about things like social distancing, use of face masks, issues and safety in indoor and outdoor environments, on public transport and so on? And the answer is because the research endeavour hadn't invested in those areas. We had a standing programme of pandemic research response, very much informed by SARS and prior pandemics, which was very biomedically focused. So we were good at the biomedicine, less good at some other areas, less good at the social science. Our understanding of behavioural interventions and how you make them work best was less good than it should be. So kind of going forwards, I think we in Health and Care Research Wales, with others, need to be really smart about spotting the places where research can make a difference and be really useful to the NHS in Wales and to government, and trying to bring that science alongside policy. So let me give a really practical example. One of the things that's happened as a result of COVID is that we have seen a transformation of the use of digital and virtual consultation in primary care, but also in secondary care and in other areas like social care. I think there's a really important place for research to help us understand what of that transformation that was done at scale and pace in an emergency has been really beneficial, what some of its problems have been, and how we use it in the future to make the sort of outpatient and primary care delivery system better. And so that would be one example I'd give where actually, yeah, we could put more money into research around that as a priority.
Thank you very much, Kieran. We're out of time now.